In many cases, the way we look at how effective providers are in delivering care is based on what researchers and clinicians think. It does not include the patient viewpoint. The goal of the Robert Wood Johnson Foundation grant was to really understand how patients look at good care. We worked with a very large group of people from our Patients Like Me online community and another very innovative community-based health center, St. Matthew's Outreach, to interview patients. Patients Like Me is a community of people with chronic diseases. It's a very broad community, so that gives us access to a lot of different opinions about what good care is.
People need to educate themselves to the extent that they're more likely to get care that conforms with what they actually want. It's not enough to say that you want the best outcome. You actually have to define what that outcome is.
But it is also important to really go out into a community situation to see what others think. We asked patients to simply give us a list of what they thought represented good care. We were able to boil that down using what's called concept mapping into 10 basic concepts. These included things like an active patient role, working with a competent professional, how the professional worked in collaboration with the patient, was care individualized, and also how the relationships with the rest of the treatment team and even the office staff took place. We know that people who don't feel these things might have a greater likelihood of not complying with the treatment, following the recommendations.
Good care to me is someone providing me the information I need to know to better myself or possibly stay around long. It's important that who I go to is for my best interest.
I think there's a lot of individual ways that people can apply this information. Really look at some of the factors that we found here. You certainly want to see, number one, does the treatment work? Do you understand how the treatment is delivered, what you're supposed to be doing? Are you playing an active role in it, or does it feel like you're just kind of flowing with the recommendations that are being given to you? Do you feel like you have a partner in the doctor, a teacher? Is it a relationship that feels like it's uneven? Now more than ever, we need to really pay attention to that patient role.
Hello, everyone. Thank you so much for joining us to share strategies on increasing patient engagement and using patient-reported outcomes more effectively. For those of you who don't know me, my name is Susan Mende, and I'm a Senior Program Officer at the Robert Wood Johnson Foundation. Most of you on the webinar today are fellow grant makers, so we're all amongst friends, but if you're not familiar with the Robert Wood Johnson Foundation, just let me give you a couple of seconds of background on our work. We're working with others, many of you, on the call today to build a culture of health, which basically means that we really are seeking to enable everyone in our diverse society to be able to live healthier lives now and for generations to come. So what does that mean? Well, for starters, we think that in a culture of health, healthcare is patient-centered, which is very much a part of our topic today. This patient care is organized and it's delivered in ways that are really focused around and respect the goals, needs, and preferences of patients and their families. And we all know that unfortunately that doesn't always happen in our current system. So that's why I'm very excited today to be joined by Ben Heywood. Ben is president and co-founder of a group with which many of you may be familiar, called Patients Like Me. Patients Like Me is a very innovative patient network that's really focused on helping people share their experiences in order to improve their care and the care of others who are in their same situation. There's also Emil Chiauzzi, who is the principal scientist at Patients Like Me, who is with us today. A little bit of background on Patients Like Me. It's been around for about 10 years, and it's connected more than 600,000 patients who have more than 2,800 conditions And with all of that work, they have generated 43 million data points along the way. So I think you can see that there's a great deal of experience and sharing behind Patients Like Me. Also today, I'm happy to introduce Charles DeRosa, and Charles is a patient advocate and also a member of Patients Like Me. We also have Kimminau, who is a senior scientist and chemist with the American Academy of Family Physicians National Research Network. You know, we all know that engaging patients in their healthcare is important, but I think we all wrestle with many of the same questions. What exactly is it that patients want, and how is it that we measure it? So to get to some of those questions, Robert Wood Johnson Foundation provided a grant to Patients Like Me to explore how patients themselves view good care, because isn't that what's most important? Then we worked with partners to incorporate patients' perspectives on how do you provide and how do you measure what you consider good care. So this work involved a wonderful collaboration with the National Quality Forum to increase patient involvement in the actual measure development process itself. And it also involved working with the American Academy of Family Physicians, because we need to also understand the issues of doctor and patient accountability. So today we're going to share the results of the project that focus on what's a patient definition of good health. So we've all just watched a brief video about the project that only just scratches the surface. And so we have the opportunity now to learn more. But before we get to the meat of our time together today, I want to remind you, please, that if you have any questions, share them using the question and answer button, Q&A button, and that's in the lower left portion of the webinar screen. So to kick us off, I'd like to ask Ben and Emil to very briefly explain what the Good Care Study was. I think that we all know how you define the patient perspective of good care and how it can be measured. Actually, we don't know. And so that's why we're asking them to talk about the Good Care Study. Ben?
Okay. Hello, everyone. In this study, our interest was in really beginning to understand how patients look at healthcare quality, which is often defined in terms that researchers and clinicians use, obviously very important. Patients may be involved at an early or later stages of those determinations, but in our mind, we really need to get back to what we consider at Patients Like Me our first principles, which really is beginning with the patient. So in order to really take a look at what good care was, we did not want to begin with our conception of what it is, but we wanted to have patients develop the ideas from the ground up. So we have a large community of patients with chronic diseases on our platform, and we thought it would be very useful to use a technique called concept mapping to bring lots of different ideas together and to form kind of an overall set of concepts that we think represent the patient viewpoint, which would be a wonderful starting point. So we recruited a group of Patients Like Me members. We also included some stakeholders, which included researchers, purchasers, measure developers, and others who have an interest in this area. And we also recruited people in Baltimore who were receiving healthcare of various types. In meeting with these people and with conducting this work online, we developed a list of almost 2,000 ideas that patients came up with. And we were able to bring those down to a set of concepts that we had people rate and sort into different kinds of concepts. After producing a concept map, which I'll show you in a minute, we then went back to a community clinic that you saw a little bit of in that video and reviewed these ideas with patients who were in an underserved area, and actually we were able to receive a lot of validation for the ideas that the other groups came up with. So I can briefly show you what that map looks like. And it's a good way to really take a lot of different ideas and organize it into a set of concepts.
Put the slide up. Oh, there we go.
Okay, there it is. Okay, so what you can see here is a fully formed concept map, and it actually broke down into 10 major ideas that the patients came up with. Some of them had to do with outcomes, as you might see with researchers and clinicians. It's certainly important. Does a treatment work? Some of it had to do with the structure of treatment. Was it collaborative? Was there information going back and forth that the patient could use to understand what the choices were and what was effective? Some of it had to do with an understanding that this provider is able to competently deliver the care. Communication, which we often hear about, was another major piece. The ability for the patient to remain active throughout the process, and that process begins from the first visit and a diagnosis all the way to follow-up. And then finally, even dealing with the logistics, the insurance, the office management. All of these have an effect on the outcomes and the patient consideration of quality, which goes well beyond what we might consider typical measurements of satisfaction.
Great. And there's a detailed white paper on that you can get access to, and we'll give you information on that later. So the other thing, as Emil said, we really wanted to look at first principles of good care, really going to patients and start from the beginning. But the other thing we wanted to look at was using patient-reported outcomes, patient-centered outcomes in the context of quality measures or performance measures. So that's where the collaboration with NQF came in. Quality performance measures are really how clinicians in the system judge and reimburse for care. And as Emil mentioned, they're typically designed around clinician or research-defined outcomes or process measures, and don't really look at patient value. And so we wanted to look at how you could include patient input, patient experiences into that process. And so we were working with 3 measure developers, performance measure developers in multiple sclerosis, rheumatoid arthritis, and COPD. We actually included our patient community in that process at different points along the way. So in the COPD process, we looked at one that was a little further along, and we got input into that process. MS we got earlier in the process, and then with rheumatoid arthritis, we actually had a really detailed report describing the tens of thousands of patients in our system and their experiences with disease given to the measure developers and for the upfront strategy and development of that process. And I think, really thinking about patient value and how they see it is fundamentally different when you start there, as opposed to going from the system out, you go from the patient in. And I think, they really are key to measuring patient value in the system. So, I think fundamentally, getting people to start and end with the patient is really key. We found that we were empowering our patients who were participating. So historically, patients sometimes participate in panels or other ways in the process, but they're in the room with clinicians and experts, and they often feel less empowered to voice their opinion. And so we really found that was dramatically different to give them that data and the information from our community to back up that power. So that and other outputs from the grant are available, and I'll throw it back to you, Susan.
Thank you both. I think that very often when we talk about patient-reported outcome measures, we struggle. I think many of the people on the phone or the webinar with us can relate to that. We struggle with really hearing authentically and involving patients rather than just a token way. And also, as you said, really getting patients themselves to define what are these components of good care. And I think, we got 2,000 ideas you talked about, and it's really great that you were able to break them up into different groups to try and make some sense of them. But, Ben, I know that you have really been at this work for a while with PatientsLikeMe, and I would love to just get a sense from you about what was most surprising to you about this aspect of the work, because I think that some of my fellow grant makers on the phone really are so committed to authentic patient voice in patient-reported outcome measures. So can you just share some insights with us?
Absolutely. So, I mean, one thing is, I think, obviously we've been using patient-reported outcomes directly with patients for over 10 years in our communities. But I think, what's still surprising every time I go into this and work with experts in various parts of the healthcare system is the resistance to thinking of patients as key sources of data and evidence, and actually, quite frankly, of experts in their own disease. I think that's still pretty prevalent. And I think one of the things funders can really effectively do is drive change in behavior and force researchers who are getting money to evaluate and study problems in this space to really think differently. And actually, Susan, one of the things that you continue to emphasize both as we started into this grant and throughout the grant was really getting the voices of underserved populations. And that was why we took the research from our online community and went into a community population in Baltimore. And I think, again, that was out of continued your voice actually in the grant. So pushing on that and emphasizing the importance of that. And I think broadly going to patient input, I think funders really have a lot of power over the research and forcing that. I think the other thing that's interesting is bringing disparate groups together. And so one of the things I was slightly surprised about is obviously performance measures is a very sophisticated, measure developers are very sophisticated, and so are patient-reported outcome developers, which we've worked with and know very well. But surprisingly, those two don't intersect, and there was very little knowledge of patient-reported outcome measure best practices in the performance measurement field when we went to work together. And just as a small example, and again, you can't emphasize this enough, is one of the developers we worked with, measure developers we worked with, said, "Oh, we use patient input all the time. We have a patient on our panel list. They may not have the disease that we're studying, but they're a patient on the panel list." And you just, that's barely tokenism at that point in time. So I think, there's a lot of influence that the funding bodies can really do in terms of forcing that and driving. What I like to talk about is raising the patient voice to the level of medical evidence, which is one of the things we work to do here.
That's great. Thank you for that so much. I think that, this idea of we don't really think that patients have anything of value to say. Nobody says that out loud, but I think that in some situations that really is a pervasive thought, and it's so clearly not true. And I think you've really proved it, through your work. So now, actually, speaking of patients, I would like to turn to Charles DeRosa. And Charles is an advocate, and he's also a member of PatientsLikeMe. And Charles, can you share with us how you participated in this work? And also, as you're talking about that, can you also share with us what good care means from your perspective? Thank you, Charles.
Oh, sure. Can you hear me out there?
Yes, thank you.
Okay, so my name is Charles DeRosa, and I have autoimmune diseases running my family. So 5 years ago, I was diagnosed with multiple sclerosis. So I got involved with PatientsLikeMe, and I was eventually I was asked to be involved with some of the pro and prom development that was being done with Center for Medicare and Medicaid Services, and also with the National Quality Forum. So we were trying to develop a measure there that was basically the patient view of good care within the interaction with your neurologist. For when you see the neurologist, which to me is only a once a year 15-minute interaction. Okay.
That's great. And so that's a really wonderful background. Can you talk to us a bit about what you're comfortable sharing about what you think engagement is and what you consider good care for yourself and perhaps for other people with whom you've spoken?
Okay, sure. So for me, good care, it involves quite a lot of different factors. When I was first diagnosed, when I went to a neurologist, I was presented with this list of a whole lot of different medicines that, were the available treatments at the time. And, as someone with a malfunctioning brain, it's very difficult at that time to really try to understand all of these different medicines, which one would be the right one. So in that scenario, you kind of have to just trust. Well, you do one of two things: either you trust your neurologist fully and say, okay, yes, whatever you want, that's the one for me, or you say, okay, I'm going to have to go to outside sources and see if this makes sense for me or not. So that's one of the things that actually drew me to Patients Like Me, was that there's no place that you can see relative effectiveness of medicines. You will not find this anywhere on earth. You won't find it from the manufacturers. You won't find it there's no government agency that does this anymore. You can't say, of these 12 medicines that are out here, which one actually works, what's the relative effectiveness, what's the side effects. You can't do that. It's impossible. So Patients Like Me was the only one that could do that. So for me, good care, part of that was the data, was really getting at the data. And then, part of the interaction was, the good care was, okay, am I getting better? Is what you're giving me actually working? Is it making me better? And, am I getting the other things that I need from this? Is there side effects? Is there things that I need to get done? Is there interactions with insurance companies? Is there, am I scheduling my MRIs? There's a whole lot of factors, blood tests, all kinds of things that you're gonna deal with as a patient. It's not just that one interaction, and I think that for me was the interesting part of dealing with National Quality Forum and the Center for Medicare and Medicaid Services. Was, I think in essence, they were trying to measure just that interaction when it's a much wider spectrum. You're from a patient's perspective, it's more about their relationship of care rather than the individual instance of care.
Thank you. That just makes so much sense, because, I think that we recognize that very often information is presented in little slices. And also, as you say, the information that's critical to you may not be the information that you're getting, and in a way may not be the information that some of your clinicians have. But Ben, if I can just turn to you for a second on this. I know that over the years you have, heard from so many patients. Is this experience that Charles is discussing, have you found that other people have gone through this in terms of not being able to get information and having it be very siloed?
Yeah, no, absolutely. And I think that's one of the challenges in the healthcare system, is that a lot of this data is very siloed, and it's very hard to, historically, it's been hard to aggregate the collective experiences of patients. That's one of the things we're focusing on as a way of getting, the real world experiences and turning that into medical evidence. I think the other thing I'd love to talk about is an experience that Charles has described to me, as well as some of the other members, patient members of the rheumatoid arthritis work we did, which was having the aggregate data of thousands of patients in a report as part of the measure development process. When they were in the room, they felt much more empowered as experts than they historically had. Because I think one of the challenges is when you put a patient sort of in the room, which is a starting point, but not really where we need to go to, but it's a good start, is that they are often overpowered by the experts and clinicians and don't feel that their voice has as strong a meaning. And I think when you begin to aggregate data the way we have and is possible out there, and really bring thousands of patients' voices into the process, it becomes a much stronger, more meaningful level playing field, where the expert opinion of patients and the expert opinion of clinicians and researchers are all aggregated to get to the right answer. And it's not to say one answer is right or wrong, but you want symmetry in that, in those voices and that evidence driving the process. And I think we really saw very specifically that patients were much more empowered through having our data as part of that measure development process.
Thanks. And Charles, can I turn back to you for just a minute? So from your perspective, as yourself, of course, and from other people and patients with whom you've spoken, do you have a sense of what area of what we call patient engagement really needs the most work, perhaps needs more funding and exploration? Can you share your thoughts with us?
I think there needs to be I think there needs to be more work on, I don't know if I'd call it credibility or believability of the data, but you know, I think what happens in these forums. So and I shared this a little bit in our last talk was, you have a whole lot of extremely powerful, extremely well-educated people in the room. They're PhDs, they're you know, doctors, they're, you know, and they're used to very hard data. You know, they'll only believe, you know, hard scientific studies. And this concept of, okay, well, if it's patient-reported outcomes, they almost treat it like hearsay. You know, it's kind of the prejudice that, you know, a lot of the very educated people have towards anything that's coming from the patient community. It's almost like they don't want to believe it. So I'll share just a little story. So I was at the National Quality Forum, and there's a very prominent neurologist sitting right next to me, and there was a representative from PatientsLikeMe there who put up a slide that said, okay, you know, these are the reported symptoms from, you know, this entire thousands and thousands of patients. These are the most reported symptoms for multiple sclerosis. And they listed all these ones there, you know, on what percentages not each person, overall the percentages of people that said that they had this and that and the other thing. And one of the measures there was actually sexual function or dysfunction. And the neurologist who was sitting right next to me, you know, he was looked at the slide, and it was something like 60% or so of patients said that they had that. And he says, "Oh, that can't be right. You know, it's, in my experience, it's 100%." And I'm thinking to myself, Doc, like, hey, look, okay, so I got my son right here, I got my daughter right here, and I'm pretty sure it's not 100%. You know, it's maybe pretty prevalent, but it's not 100%. You know, you're not listening to the patients, you know, and you're developing the measures, but, you know, you can't see what you can't see, because, you know, if you don't trust the data that's coming from the community, you'll never act on that data. So to me, that's the biggest factor is, you know, how do you get the trust of the you know, the medical community to trust this set of data that's coming from us, you know, from the patients? You know, how do we make them believe this? Because right now they don't.
Thank you so much. You know, I think you bring up such an important point about, you know, what we consider valid data. And I think that there are so many myths and misconceptions about that, and certain judgments about that. I think that that's so critical. I'd just like to thank you all. I'd just like to remind people that if there are any points that you would like to hear further about, or any questions that you'd like to submit, please do submit them, and we will be keeping track of them, and we will get to them, you know, in a little bit after we hear from a couple more people. So thank you. So let's bring the clinicians into this conversation. Kim Kimminau is an associate professor at the Department of Family Medicine at University of Kansas Medical Center, and she was also the research director of the National Research Network for the American Academy of Family Physicians. And she was really a great support and a great help in the work of this project. So Kim, can I turn to you for the clinician's reaction to what we've been talking about? What's the provider's perspective? From your point of view, from what you've heard from your colleagues, is this welcome feedback and seen as a really great opportunity and a mine of information? Or are some people seeing it as a potential threat, thinking, oh, we already have so much to deal with in our daily life and our daily visits, and, you know, everything is changing around us in the healthcare system, you know, and this is just, you know, another point of pressure. And how do we increase the accountability in this way, the accountability for both providers and for patients? Love to hear your thoughts on that.
Well, thanks, Susan. That's a very big question, or a set of questions. I guess my answer is yes and yes. So yes, clinicians welcome this, and yes, it is also overwhelming. So I think the leadership that RWJ plus PatientsLikeMe is bringing to the issues are really, really important. We're thrilled, and thank you again, Patients Like Me, for involving the AAFP National Research Network. It took me a split second to say yes when Emil called and said that we had the opportunity to do this research project together. So what I'd like to do to get to your question, Susan, is talk just a little bit about this augmented element of the overall project that involved bringing questions to the clinicians, to family physicians, and give you a little flavor of the physician's perspective, just as Charles did such a great job of bringing the patient view to the table as well. What we did was, and I'll tell you, we thought it was an ambitious goal to try to recruit 15 family physicians geographically dispersed across the US to participate in a discussion, a dialogue about accountability, about what they perceive to be their accountability for providing good care. And interestingly, also what they thought patients thought about their role in accountability. And at the same time, we were working with physicians to bring their voice to this issue. Patients Like Me were running an exactly contemporaneous online communication discussion as well. So these were snapshots of patients as well as clinicians answering essentially the same questions in the same domains about mutual accountability for care and outcomes. To begin with, I thought it was ambitious, as I said, to recruit 15 physicians. We wanted to do it fairly quickly, and we had a ready group of our physicians who were involved in our national research network. But honestly, I was hopeful that we would get the 15. And within less than 3 days, we had 17 volunteers. So we were delighted that clinicians and family physicians really were eager to participate in this conversation over the course of about a week using an online chat feature so they could talk with one another, but also answer some directed questions. In terms of the clinicians who answered, and I'll let, of course, the PLM colleagues talk about the patients, but we had a good cross-section of physicians representative, as I said, overall, in terms of rurality, whether they worked in safety net clinics or in private practice, if they owned their own practice, or if they were part of an accountable care organization. We were mindful to select a really diverse set of voices to bring to the conversation. And as I said, we ran a set of questions so that we asked for their feedback, but also asked them to volunteer concerns and issues around about 6 of the core domains that you saw in the graphic that was already put up that had been identified as critical to patients. I'm going to jump to the conclusions and the summary of first, the biggest takeaway. By far, the biggest takeaway is that while we don't have family physicians and patients talking together in the same way, they actually revealed a lot of common concerns and common approaches to the issues of their mutual accountabilities. So good news here is there was very good alignment between the family physicians we asked and the patients' priorities as well for how they share accountability over care and care planning. That's the good news. The other piece of good news is that they both pointed to some of the same key issues that stymie their satisfaction, that influence the kind of care they think they give or receive. And far and away, the most important component to both groups is effective communication. Having effective communication, being able to ask and answer questions, to feel respected and recognized for perspective, for taking the time to making sure that there's common understanding was just seen as crucial for both physicians and patients. I think the communications piece and also the relevance of care coordination for patients who have chronic illness, frequently they get their care not only from their family physician and their primary care provider, but from a whole suite of other specialists. And patients, as well as the family physician, who frequently sees themselves as the quarterback of that care, they're pulling information out from maybe radiology or from some other treatment specialist. They see their responsibility as being the hub of information to help support the patient. But at the same time, patients see they have to step up and encourage the kind of communication sometimes they think is happening behind the scenes, but doesn't always happen very effectively. So our patients were saying, gosh, I wonder why my doc doesn't know about this test, this result, this course of care, because they've made the assumption that everything is stitched together in a perfect quilt through the electronic health record. And what they learn, as well as what the family physician learns, is that sometimes this information is asynchronous, it's not integrated, sometimes it's missing, sometimes it's redundant, and it frustrates both the patient and the family physician because it stymies executing that care plan and requires all sorts of rework on both of their parts, leading to frustration and, again, poor communication. So both patients and family docs agreed that their mutual accountability for making sure the information that's essential for the patient activation, for the patient's activation, as well as the physician's timely activation, are really crucial. And then my last point, I guess, would be that they also see this whole issue about communication really being relevant for an ongoing review of a care plan with a patient with a chronic condition. It is not a one and done plan. It changes based on the health and status of the patient, their family, their overall living situation. There's a lot of appreciation on the family physician side that life influences care plans. And so needing to go back and look at that care plan together was recognized by both patients and physicians as being something really desirable, but limited in terms of time, cost, and effectiveness. So the communication effectiveness, the ability to review care planning, the mutual coordination, and then effectively together making sure that both parties understand what the patient's objectives is for outcomes are really essential. So there were very, very few points of discord and mostly a unanimous call on both patients and providers' part to really focus on better listening, better active listening and communication to help advance these points.
Thank you, Kim. It sounds like there was so much deep work in this, in engaging physicians, and that in many cases, certainly, what patients are seeking and what physicians really seek for themselves and for their patients in terms of, really understanding where the objectives are, where both people need to go is very critical. So thank you for that. Charles, I'd like to turn to you, if I may.
Sure.
Can I query you? I know that we talked about, there's more research needed in this area of how we get patients' voice really engaged and how we get patients listened to. But are there any other tools or resources that you think would be helpful to help patients be more engaged in shaping their own care?
For me, what I would like to see, which is going to be a very, very difficult thing, I would like to see a breakdown per disease of every medicine, every treatment that's out there for that particular disease, with things just made clear and plain. So if there's 15 treatments on the market for MS, lay them out side by side. Let's see them. It doesn't exist. You can't see the cost of them. You can't see the relative effectiveness of them. You can't see the relative side effects of them. You can't see the relative dangers of them. Can I not use this one because I'm positive for the JC virus in my brain and someone else doesn't have that? You can't do that. That type of analysis has never been done. So there is no essentially, cheat sheet or reference guide for a patient to say, okay, of everything out here, I don't have the information to go back to my neurologist and say, hey, look, you're recommending I be on this one, but I want to be on this one, and I think this is why. That doesn't exist. It's the power relationship between, the patient and the doctor is very one-sided. I mean, to tell you the truth, when I first diagnosed, all of the oral medications were pretty brand new on the market. The doctor at the time recommended that I get an injectable that had been on the market for a few years. And, I had to fight really, really hard to, with my wife advocating for me because I wasn't all there at the time, to get onto one of the, the brand new released orals. And I've been on that one ever since, and it's been great. But, if it was up to just following what the doctor said, I'd be shooting myself up with needles twice a day, every day for the rest of my life. And, my life would be terrible. I hate needles. I can't stand them, but I'm extremely needle phobic, but that wasn't a factor in how the neurologist saw it. The way the neurologist sees it is, okay, this is clinically proven. It's been effective for this time. It's been out for this time. This is what you should take. And, the patient's not going to see it that way. And, but we don't have the tools to go back to them and say, hey, look, doc, that's great, but, this is the one I want to be on. And that's what I would love to see developed is for every disease out there, the relative comparison of all the treatments that are out there, including the costs and the side effects.
Great, thank you so much. And I think, you're really bringing up so many key points, amongst them, what's out there and what works for me, not for, some anonymous patient. And then, of course, also, the power differential is, and I think that keeps coming up in so much of the work that we're all doing on this. So Ben and Emil, you've been working at this, as we said, for many years. You've heard from the other speakers, and I know that you're continuing the work, of course, with Patients Like Me. So we have a question about where do you think, where are you planning to go from here?
Well, so I think a couple things. One is, I think, driving the use of patient-generated health data or this type of data into the system is something we're going to continue to do. And we're actually, Patients Like Me is actually going much deeper than we even historically had done with patient-reported outcomes, where we're measuring using novel new biological measures to understand proteins in the body and the microbiome and obviously the genome. And we're actually not just doing that in a clinical or a research setting, but we're actually, again, going to patients, enabling them in that data, and then seeing how patients can influence the system with novel and new ways of understanding their disease. So that's really what we're focused on. I think, a couple of takeaways from the grants, just from what we were talking about. I think, in terms of other funding opportunities, one of the things we explored with the physician AFP and our thing that I wanted to go personally even deeper on, but we just ran out of time, was really sort of understanding how, reimbursement should be viewed when, you're looking at patient outcomes and physician outcomes and that how much the physician is accountable to the end outcomes of the patient if they're driving some of the outcomes. The other thing is, I think, just take away as it relates to, systemically how the system reimburses, physicians are not happy with performance measures either. They know they're not measuring what really matters, what really value. And I think that came out of the work we did do with it in terms of understanding that there's a sense that we're not measuring what matters in the system, and that's a key. And I think we need to continue to really look at what matters to patients.
Thank you. Okay, can I turn back to you for a moment, Kim? We've heard many thoughts on this webinar that we've been able to spend this time together focusing on this such a critical issue that so many of us are struggling with. And we've heard a bit from Charles about, from his point of view, what else needs to be done and what would be very useful to patients from his experience and from people with whom he's spoken. So Kim, from your point of view, just very briefly, what do providers need in order to move further with this work and to really change perspective?
Thanks, Susan. That's a great question. I think they recognize as much as anyone that their skills in communication, particularly because of the breadth of their patient population, could always be strengthened. So their skills around active listening, on teach back, on ways to elicit information from folks who are culturally, linguistically, socioeconomically different than they may be, is something they recognize that not only do they need as physicians, but they need support for their entire clinical team. I'll point out that patients point to the entire clinical team as the source of their support, particularly in a community health setting, but elsewhere as well. They build relationships with that entire clinical team. It's not only their physician. And I think the strength of the team-based model of delivery of primary care, which is a hallmark of family physician medicine, it is something where the strength in communication skills, in appreciative inquiry, and the kinds of tools we know are there could really help strengthen the capacity of the primary care team to support patients' needs. So physicians say that themselves, and patients, I think, recognize that their skills can be strengthened. So it's really a bidirectional support for communication. That's a key area. That's an opportunity, I think, for improving skills. Beyond that, the larger question are obviously the health systems questions, which is the constraint of time that often is needed at even greater amounts based on the complexity of the illness, the novelty of the relationship, and the distance or difference between provider team and patient. So if there are cultural differences, if there are linguistic differences, these things add enormous amounts of time, and no one ever wants to feel rushed or hurried or shut down. But when our visit timeline or time available for a visit may be in 15-minute increments, it's simply not enough time for that clinical team to hear everything that Charles needs to share about what's happened since his last visit, for example. And then you add to that perhaps a language difference between Charles and his provider team, and now we have an interpreter. And that adds even more time. So I think the time constraints from a systems perspective in a primary care environment, at least, is really quite substantial and important to note.
Thank you. So building on that, just very briefly, if I may turn back to Ben and Emil, Kim's just talked to us about some of the really barriers that physicians face, such as time, such as cultural difference, such as perhaps not always being able to deliver care in a team-based way. So just very briefly, in 1 minute, can you talk about what kind of policy changes do you think we're looking at to start to address some of these issues? Either Ben or Emil?
I think that it's important to consider how you can bake in patient involvement at a very early stage so that we don't end up in the type of situation that Charles is talking about, where he's coming in at the end of all these discussions, determinations, decisions. I think it's very important to include people very early, even in the research process at the beginning. And to make that a necessary piece. We see this happening in other countries. In terms of health technology assessment, they are expecting to have patients involved in making decisions about what innovative treatments are going to be offered. And I think that unless that is baked in maybe even a regulatory way, it's going to be hard to make significant changes.
Thank you so much. So it's really around, we have to start always with the heart and get to the mind. And so I think that, all of you have brought up so many critical issues about attitude and beliefs and experience and that really need to be addressed along with so many of the other levers that you have talked about, including policy levers. So, unfortunately, it's time for us to leave this, what I thought a very, very interesting conversation. I'm sure many of us have other meetings that we have to rush to. So I'd just like to take this moment to thank all of our panelists, not only for joining us today, but really for your deep commitment to this work and for all that you have done and that I know that you're going to continue doing to really, really work to make a system that for real has the patient voice and the patient objectives at the center, all the way from practice, research, you name it. So I'd also like to thank our audience. I know that this is a Monday and it's always very tough to get on anything on a Monday. So I appreciate your sharing your time with us. You can all learn more about Patients Like Me at patientslikeme.com. And we will send a follow-up email with links to all the information that we shared today, as well as a recording. So thank you, all of you, for joining us, and have a wonderful day. Bye.
Thank you.